Every minute, someone's life takes a terrifying detour, not down a dark alley, but into the sterile, bright halls of healing. They walk in seeking care and find themselves plunged into a nightmare. Most malpractice claims in hospitals are related to surgical errors, whereas most claims for outpatient care, which accounts for more than half of the paid malpractice claims, are related to missed or late diagnosis. Now, before you raise a pitchfork at every white coat you see, let's be clear. This isn't an indictment, it's a revelation. Because the truth is, any provider, any nurse, any human being capable of brilliance is also capable of a mistake. This is about understanding why and using that knowledge to build a safer future for every patient who walks through those doors. Welcome to FHEA's Scrubs and Subpoenas, Tales from the Witness Stand, a podcast where we'll peel back the sterile sheets and delve into the real stories of medical malpractice. Each episode, a cautionary tale, a blueprint for change, a reminder that even in the darkest corners of human error, there's a light. The light of knowledge, the light of empathy, the light of a future where healthcare becomes not a gamble, but a guarantee. So join us as we dissect the mistakes, illuminate the flaws, and ultimately learn to heal not just bodies, but the very system itself.
Okay, so one of the things then I have a question about, because this is what I'm thinking about as you're talking. I hear in the back of my head, if you didn't chart it, it didn't happen, right? Like, and I know that's a hard and fast rule. I learned it in nursing school. I still hear it. I still hear it through, everywhere. Every nurse that I ever come across, we kind of still have this same trauma that we all carry around. And there's a part of me that I feel like, yes, like that's true. If you didn't chart it, then how in the world could you ever prove that it ever happened, right? If I was the NP, I want to say on trial, but that doesn't sound right. But if I was the NP, that's in front of this case trying to say, no, I did this. I did this. I guess it's not on the chart, but I do remember, that I did it. It almost feels like, where's the grace, right? For like that, because to your point, there's a really realistic way on how this happens, like how you really do chart and how this occurs. But yes, there's a whole safety aspect that we must be cognizant about our charting. We must be good with our charting and complete and thorough. But like, how does that actually show up in real life? That whole, if you didn't chart it, it didn't happen. I imagine attorneys tell you that all the time. I'm just going to tell you, I imagine attorneys use that line all the time.
So I do. One attorney asked me during a deposition exactly that question. He said,
Oh,
"Are you familiar with the phrase, if you didn't chart it, it didn't happen?" And I said, "Yes, I am." And he said, "Well, what do you think about that?" And I said, "Whoever said that doesn't take care of patients. Really,
mm,
whoever said that is the pure academic,
yeah.
you know?" And because that's the truth. Whoever said that doesn't really go through the day to day of trying to chart every single thing you do. There's the ideal way, and then there's the real way, and then there is the deviation from standard of care. And so since the issue with malpractice actions is always about the standard of care, it's not about the ideal. The NP isn't held to an ideal. I mean, we all personally hold ourselves to that ideal, but that's not the legal standard. The standard of care is what the same or similarly licensed professional would do in the same or similar circumstances. And it's very common that there are things that we don't chart or we forget to chart sometimes. I mean, we're just human, and that's the nature of the job. And so there is an allowance for that. I mean, there is an allowance for humanity, and there's two things that we can look at to protect ourselves there. One of them is that it is very appropriate in a deposition to say, I didn't chart it, but I did it. I know I did it. Either like I remember that patient, I remember that
Yeah.
circumstance, and I did that. And deposition testimony is sworn testimony. And sometimes I actually think that that's more useful because I mean, it can go either way. Sometimes it seems more useful because if the person really remembers that they did or didn't do something, they have a clear memory of that, like you're getting their impression right then. It made enough of an impression on them that they remembered the circumstance and they can tell you what
Yeah.
they did or didn't do. And it is sworn testimony. And it's one of the things that juries consider in making their decision. So there's that. And then the other thing is that even if you don't remember, but you know it's your custom and habit or your custom and practice. That's a common phrase in this business of testimony and legal interviews or documentations, that someone can testify as to their custom and practice. So, okay, the chart says I didn't order this test, but it would be my custom and practice in that circumstance to do so.
Oh, okay,
So
like, you just
I'm
kind of always do that.
I always do that. And so a test might not be the best example because the test result is usually there, but you might say I gave a verbal order. It would be, you might say I gave a verbal order and it was never reported.
Yeah,
Well, it would be my custom and practice to do that. And I don't know
yeah,
why it wasn't reported and carried out. It may be that the MP gave an order to, the bedside nurse or to whomever, and that person, for whatever reason, didn't didn't record it, didn't understand it, didn't carry it out. And then, of course, then looking at the MP, well, why didn't you order this thing? And it's appropriate to say it would be, I don't remember the case, the patient, I don't remember the case, but it would be my custom and practice to do it. And that's
okay.
an acceptable and appropriate response. So it
That's
is.
interesting.
And
That's
it really is important to emphasize the difference between the ideal approach
yeah,
versus the real world, what another MP would do in the same or similar circumstances.
yeah. And I wonder, like, does the type of charting make a difference? Like, I'm saying back in the day, now I feel like super old now saying this, but like narrative charting versus when EMRs came along, right? And it's like click, 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 click. I mean, it was easy, it was great because like you're in and out. Like I can just click what was weird and wrong. I don't have to do anything more detailed than that. But I wonder if there's a difference from a legal perspective, like we chart by exception. So only talk about the things that are wonky, right? That are awkward, off, not normal. Or you have the very narrative, this is a story, and I'm sitting down what feels like 10 minutes reading this whole entire chart. And like, is there a safer charting? Like one of those are safer than the other? Or do you see more of one type of charting versus the other in these types of cases?
Well, it's funny when you say you feel ancient. When I first learned how to chart, we chiseled hieroglyphics on a stone pad.
Stop.
So I can totally identify with the sentiment. Um, Much more often now for the NP role, you
Yeah,
see charting by exception.
right.
Bedside nursing, even because everything has become electronic now, that
Yeah,
bedside nursing is more click and pick menu than it used to be. I mean, it used to be that the bedside nurse wrote these long narratives, these long
yes,
nursing notes, and then the
yes,
NP would I mean, charting by exception really is a SOAP note because a SOAP note is just supposed to give you what's relevant. Um,
yeah,
Listen, this is just an opinion. I don't know that there's any great authoritative reference that would support one opinion or the other. But I think as a rule, the less we write, the better. I mean, the more you write, the more it's subject to interpretation and being picked apart, you know?
yeah,
So I think the less the better. But the key there to charting by exception is to remember that both pertinent positives and pertinent negatives need to be there. So it's not like if the patient comes in with chest pain, it's not
yeah,
just the pertinent positives. It's not like the EKG changes or the presence of cardiac enzymes. It would also be, like if the enzymes were negative, you would chart that. But it's also, um, the presence or absence of radiation or the presence or absence of nausea and
wow,
vomiting, so common with the inferior wall MI. If you do an abdominal exam, the presence or absence of rebound tenderness is important to note, not just the presence of it, you
yeah,
know? So I'm
that
trying
makes
to,
sense.
yeah, trying to put together a good example on the fly here. Like maybe if a patient comes in with lower abdominal discomfort and you do a history and it's sounding like the pain's in the right lower quadrant and you examine the abdomen and you don't appreciate any rebound tenderness, so you don't put anything about it in your note. if you appreciated rebound, you would document it, positive rebound
Right.
tenderness, and then you would know it was likely a surgical abdomen and, go forward. But the absence of rebound tenderness is just as important to document because if when you examine the patient and the abdominal exam is benign or non-contributory or no appreciable findings, no rebound tenderness, and you don't chart that, and then of course there are appendix perfs in 6 hours and they, get sepsis and die, it
Yeah.
really supports your disposition of that patient. If you see the patient in the office and they say my abdomen hurts and maybe I'm constipated or whatever, and you do an exam and the exam is normal and there's nothing to really concern you, you're going to send them home with
Yeah.
a plan that says if it gets worse, come back, but you're going to send them home. But then if they wind up in the ER that night with a perfed appendix and they go into septic shock, of course, in a couple of years, a bunch of people are going to be looking at your note. And it really goes a long way that you documented the absence of rebound tenderness in a situation like that. So, charting by exception, I mean, I definitely think it focuses us more on what matters. The thing about the narrative, it always takes me back to that general impression of the more people talk, the less they say.
Yes.
You talk a lot. I say this as I'm talking a lot. We talk a lot when we're not really sure what we're talking about. So we just try to
Yeah.
say everything and hope that
Yeah.
something's right. And it's like raising a teenager. When you say, "Where were you last night?" Oh, well, mom, you wouldn't believe it. Well, first, we started off here and we were just going to study there and everything. But then so and so said they were so thirsty and they can't study without being thirsty. So then we had to go to the store to get soda. It's a lie. There's a lie in
Yes.
there. There's something they don't want to tell you. Where if you say, "Where were you last night?" Like, "Oh, went to Jack's. I know you don't like it, but that's where I was."
Yeah.
So I just feel like the more, I mean, I've heard that principle so many times. When I wrote my dissertation chair said it was not allowed to be more than 100 pages because if I didn't know it well enough to be concise, I didn't know it well enough to write about it.
Oh, wow.
Interesting. I really have held on to
Mm.
that as a teacher. So same thing like on your notes. If you're not sure what's going on, we get these, and it's a holdover from bedside nursing where we're taught to write these big, long,
Yeah.
flowery things. But I think we're best served to stick with what matters, but just keep in mind that the pertinent negatives are as important as the pertinent positives.
Yeah, I'd never thought about that, and I think, I mean, quite honestly, sometimes I feel like my brain got rewired to, like, the clicking, so it's like you only are looking for the things that are
Mhm.
the abnormal stuff, but you're not kind of covering the fact that, yes, I recognize that this could have been X. I checked for X, it's
Mhm.
not, like, it doesn't
Mhm.
have any of these signs. That's actually a really good point. What about, in your experience, some of the things that we talked about, we've talked about so many good like charting tips, but has there been any things that like float to the top for you and your expert witness experience as like these are the really common mistakes that I see in documentation or charting. Like these are the common pitfalls that have occurred that have really played a role in this practice, in this or medical malpractice case rather. Like this charting error or this charting omission or this charting, mistake really made a big difference in the case.
The things that come immediately to mind. I mean, one, and it's so unique to NPs. I really have never
Yeah.
seen this. I mean, I don't serve as a witness for physician care, but in the course of going over charts, I read all of it. So I see the physician notes and I see the NP notes. And NPs do this way more than physicians is documenting that you don't really want to do what you're doing, but you're doing it because the patient wants it.
Oh, that sounds bad.
It's not good. You really don't wanna write a note. And listen, it's not as like, "Oh my god," as it sounds. I swear I almost did it yesterday. I almost did it yesterday, and I was laughing at myself when I realized it going, "Oh, Miss Expert, look what you're getting ready to do." But again, that different perspective we come from, and I think we try very often to be more accommodating. The physician was raised in the world of, I am the expert, you are the layperson, I tell you what to do, and you need to do it. And
Yeah.
we're supposed to be getting away from that. It's shared decision makings. And so it is appropriate to dialogue with a patient and say, these are options. here's good and bad of each. This is what I think, but what do you think? That's very appropriate, and that's what we should do. But at the end of the day, you don't want to do something that you think is wrong, and you don't want to document that you did something you think is wrong. And I do see that. Like I've seen that where um, in fact, this is another case. I don't know if we ever talked about it. If not, I'm sure we'll talk about it next time. But like this patient had had back pain for a very long time, and a couple of different visits over a period of a year or two, and the patient kept coming in, and then at one point the NP suggested an MRI, and the patient didn't want to do that. The patient wanted to try physical therapy first. So the NP was like, okay. So she writes in her note, that the patient wants to try physical therapy. So they didn't do the MRI, and of course there was like this big cancerous tumor back there. I think we did talk about her.
Yeah,
Yeah.
yeah, we
So
did.
so I mean, you just don't like we've said, then you can't force somebody to do what they don't want to do, but you don't document that this isn't right, but you're doing it
Right.
because the patient said. um, there was another circumstance. Oh, they always come to mind earlier on, then when I have to like regurgitate them here, I can't think of it. But NPs do that. They document that, well, this wasn't really what I thought was right, but the patient wanted it. Oh yeah, yesterday when I was one of those days, everything was taking too long, of course, trying to multitask. We were emailing
Mhm.
back and forth between patients
We
about
were.
today, and I
We
was
were.
trying to do more than I should have. And I had this one circumstance where it just wasn't clear cut. It wasn't a clear cut diagnosis. It could have been a couple of different things. And this was like the third visit. And we had been going back and forth a little bit about, this is what's more likely, this is what's less likely, and it was shared decision making. Here's what I think. What do you think? Let's come up with a plan. And it wasn't a
Yeah.
case of I didn't think it was the right thing to do. I was really on the fence about where to go. And the patient had a preference that I could live with. So that's what I was trying to chart. But when
Right.
I do practice what I preach. At the end, I go back and read my whole note from top to bottom before I sign it. And when I read it, I thought, oh no, I don't want to say this way, because it sounds like it's the patient's idea and not mine.
Yeah.
And it
Yeah.
didn't read well, and it wouldn't have read well if somebody was going to, and it didn't really reflect what I was trying to do. It's just that that's what happens sometimes when we're in a hurry and try to rattle through
Mhm.
stuff. So yeah, documenting that you're doing the wrong thing and doing it anyway, that's not a good plan. And then, I mean, the other things, failure to have a follow up, failure to instruct the patient about follow up. I do
Yeah.
see that a lot. If we see a thing and we think, oh, it's probably fine, and we tell the patient it's probably fine, and you might even say, but if this happens, come back. But if it's not written down, then of course that's a real sticking point. Like, well, how was the patient supposed to know if
Right.
that they were supposed to follow up? So really, the biggest things always seems to come down to that a complaint wasn't properly evaluated. And proper doesn't mean exhaustive. It just means some key things were missing in the evaluation. And then not having a follow up plan, or not documenting a follow up plan, and documenting the wrong thing. Those are the things I think probably come up most often.
And those are big deals. Those are
Mhm.
big ones.
Mhm.
But, on the flip of that, like in the flip of charting, like, well, I don't love this idea, but the patient wants to, so we're gonna go for it and see what happens. But on the flip of that, if the patient is not, they're not aligned with the recommendation that you're making, they're just outright saying, no, I'm not gonna do that.
Mhm.
Is it appropriate for you to say, like, I advise patient of
Mhm.
XYZ. Patient doesn't refuses to do this. I educated them on the consequences, that could happen, but they still choose not to. Like, is that appropriate to do?
Oh, it's a must do. Yeah, it's a must do,
Okay.
because that does happen. I've seen a couple of those with mammograms, where
Yeah.
a patient was advised to have a mammogram but didn't want to. Or maybe the patient had a mammogram with, an unequivocal result, or, it's like something that just required ultrasound or follow up, and the patient didn't want to do it. And like that's just that's no discussion. If the patient doesn't want to do it, of course you can't force the patient to, but you do want to be really clear on the
Yeah.
consequences and what you advise. You hear a lot of, I mean, at least I've heard a lot of, oh, my mother used to get mammograms every year and they always told her she was fine and then she got cancer. So why even bother? Like, I'm not going to get one because it didn't find it for her. So if the patient doesn't want to have a mammogram, we can't tie him down and do it. But we document that we advised and they refused. Or on the other hand, I've had patients say, oh, yeah, my friend, she had a mammogram and then they said they found something and then she had to go have a biopsy and it was really hard and it got infected and there was this big hole and then it turned out to be negative. So I'm not doing that. I mean, people's exposures and experiences are really strong drivers of how they seek healthcare, and 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 that's just the way it's going to be. But again, all we can do is reinforce the point and tell them what we think, and if they don't want to do it, document it that way. Yeah, 100%. Yeah,
Yeah.
there's a difference between shared decision making versus they flat out really just refuse to do what you advise. And I, also sometimes we just have to tell people, I can't treat you in this circumstance. Another one of my yesterday was one of those rough days, and I had a patient I had seen several times, and she has a personality disorder, and she needs a therapist. She must have a
Yeah.
therapist. I can't help
Yeah.
her without a therapist, and she keeps coming back to me looking for a pill because it's a pill society. And the first time I let her make the second appointment, and we had this conversation again, and I said, no pills. No pills till you see a therapist. I don't think a pill is for you. And then yesterday, she kept assaulting the office staff trying to make an appointment.
No.
The poor office staff, like they're sending me emails going, Sally, I'm so sorry to bother you with this, but this patient really wants to make an appointment. I said, here, I'm going to type this, copy and paste it back to her. No, no, no appointment until after you see a therapist and I have seen the therapist's notes. Then we can
Yeah.
make another appointment. So,
Yeah.
believe me, she'll find somebody to see her and give her pills, but
Yeah.
it's not
That's
going to be me because
unfortunate.
it's
Right.
just not the thing to do. Yeah.
Man, wow, this was really, really good advice. So then, what would be your one takeaway to our listeners who so far have heard a bunch of cases and I really enjoyed that. So big shout out to our listeners. And now giving them some advice on documentation. If there can be just one takeaway to say, like, hey, it's all right. You got this, NP, you got this. But just make sure that you think about this every time you're documenting and every time you sign off on your chart. Just keep this one thing in mind before you do that. What would that be?
Oh, write that note as if 2 years from now, five experts are going to spend hours digging it apart.
Mm, dang.
That's how I write my
That's
notes. I mean, and I do. I go back. I mean, I don't, I'm fortunate that I can schedule my clinical day because it's a contract thing. So I see however many I want or not want, and I schedule.
yeah.
And mostly in mental health now, but I schedule my new patients at an hour and my follow ups at a half hour. And people that do psych full time are probably going, oh. God, if only, how do you make any money that way? Well, I don't make $1 million. And I'm fortunate that I'm a faculty member, and I have a diverse approach. So I'm not doing that to pay my bills, but my choice is to do it that way, and it's purposeful so that not only can I actually spend a little time with people, but I always have a solid 5 minutes, if not more, once the patient is no longer there, that I can sit there and structure my note. It's also a good idea to try to individualize it just a little if you can. Like, it's not unusual for follow-ups that in psych, this month is a lot like last month or 2 months ago or whatever.
Yeah.
So it's really legit to copy the HPI from the last time and put it here, but try to personalize it in just like one sentence. Try to find something today that's a little bit unique that demonstrates that you actually did pay attention to the patient today and not just cut and paste. But I think
Yeah.
the big thing is write that note like experts are going to be looking at it with the magnifying glass.
Yeah. And we learned that they do. I mean, we've done enough of these episodes that we learned that they absolutely do. That's good advice.
Mhm.
That's great. Awesome. Dr. Miller, thank you so much always for joining, for having these conversations. This was great. A lot of good advice and takeaways from this. So I appreciate your time. And I appreciate everyone who's listening in, who got some good takeaways. We hope you enjoyed this episode and listen in for more drops on Fridays, some more stories. and just some more learnings that we all can take away just to be a little bit safer, a little bit better than we were yesterday. So appreciate your time. Thanks for listening, and goodbye for now.
Thank you for listening and learning with Scrubs and Subpoenas, Tales from the Witness Stand, presented by Fitzgerald Health Education Associates. Please rate, review, and subscribe to this podcast. And for more NP resources, visit FHEA.com. Join us again next time as we dissect more medical malpractice cases.